So, of course, the symposium would not be the same without Stan coming on and saying a few words. I've done the best I could in impersonating his background, of course, as you're usually used to seeing. But welcome onto the symposium, Stan, and looking forward to hearing something on the same track of medical adherence and opioid use, this time in adolescents, with you and Dr. Renee Manworren.
Yeah, no, thank you very much, Jerry. And again, thank you for everybody joining us today from all over the world, all the attendees that we're looking at and seeing join us from around the world on this really auspicious occasion where we can actually speak with Professor Manworren on about this very important topic, which is critical at this point in time as we're enduring an opioid crisis, a pain medication crisis in America and around the world. But again, Dr. Manworren, thank you for joining us.
Thanks for having me.
And if you could, just for the audience and for everyone listening, if you could provide just a 1-minute background on yourself, please.
Sure. So I am an associate professor at Northwestern Feinberg School of Medicine. My primary education is in nursing, and I am the director of nursing research and professional practice at Ann and Robert H. Lurie Children's Hospital in Chicago.
Fantastic. And tell us a little bit about the kinds of research that you're engaged in.
Yeah, so I have been a pediatric pain management specialist for over 30 years, back when we didn't think, or I always thought, but people didn't think kids had pain, which I've now come to realize is probably because we have so little research on pain, and set out to show as a mom that kids did have pain, and that we needed to really attend to how we were treating kids' pain, what we were doing. It's you mentioned the opioid crisis, and it's been very concerning that we have data on adults and very little data on kids. And so there seems to be this trickle down effect of, well, we'll just make things more stringent on kids. There are states in the United States that require now a informed consent for a child to be prescribed an opioid after surgery. We don't have that in any for adults. So just the lack of knowledge, the lack of research, the lack of funding that has really gone into investigating the best way to treat children's pain, and what's that long-term effect of treating pain with potentially addictive drugs.
Yeah, and let's talk a little bit about that. I mean, you're one of the leaders in the world when it comes to really understanding the long-term effect and how that goes and how that's measured. Tell us a little bit about the digital health technology known as ECAPS from Information Mediary Corporation helps you understand your pain medication in your studies and what you're doing.
I'm glad you asked. So one of the things that was really bothersome to me as I was seeing in the literature, and you were probably also seeing in the news media, doctors are prescribing too many opioids. We're over prescribing. And this really is a nice little catchphrase of how difficult it was to get controlled substances to patients that needed them for pain. I'll give you a simple example. You go to the emergency room because you've shattered your knee and you're going to have surgery on Monday. So they want to send you home. And if you get one pill every 4 hours, that'd be 6 pills a day. So 18 pills, but it might take a while for you to get to surgery. So they send you 20 pills, but you only use 10. And we were being accused of overprescribing because we gave you 20 and you only needed 10. Therefore, we overprescribed. But what if we had given you 10 and you really needed 20? Were you going to come back to the emergency room? What was going to happen? So what the the data on overprescribing really really came out of going back and asking people, so how much were you prescribed and what did you use? Now, Stan, I don't know if you've ever had surgery or anything, but let's say you did. So 3 years ago when you had that surgery, how much do you use? How accurate was your recall on how much you used? And the fact that we were using that and legislators were using that recall as policy. So I actually started trying to figure out how much should we be prescribing for kids? And there's a lot of research having them write it down on a piece of paper. And I mentioned earlier, I'm a mom, I have 4 kids. And, if my kid was hurting at 2 a.m, I was concerned that maybe I wouldn't write it down. Maybe I gave them something at 2:15, but I wrote down 2 o'clock. And as a researcher, I wanted to have an accurate idea of whether people really were giving it more often, which obviously if I was giving it and then my husband was giving it an hour later, that could be very dangerous. How could we really see what was happening in the home? And we often researchers often call the home the big black box of what's going on. So I had found out about the ECAPs, and the ECAPs were being used for adherence to help people actually remember to take their doses. And I said, I don't actually want to remind people to take it. I just want the data that this would give me. And I want to see if this data is the same as what they would write down. Now, Stan, I'll admit, it's cheaper to just have people write it down. So I was hoping that the data would show that what they wrote down and what the ECAP gave us was pretty much the same information. Lo and behold, I still remember I had a med student working with me on the project during the summer, and she was the first one to identify that there was a patient that 20 pills were just unaccounted for, and that it looked like they had recorded all of their things on paper on the same day, and the records just didn't match. So you had to look at that and say, gosh, which record is more accurate? What they wrote down that looks like they wrote down all at the same time versus what we were getting electronically. And as the reason I remember this so vividly is because because by law, we were not allowed to take the remaining pills away from the patient. She then became very worried about giving them back. And she said, I don't know what patients are doing with this and I can't give it back. And I just remember telling her, when you have the power of a pen, when you're done with school, remember this, that every time you write a prescription, as soon as that prescription leaves your hands, you don't really know whether they're going to follow those directions or what's going to happen with those pills. So you need to be really diligent about what's happening. And it certainly would be easier to be diligent if I was getting a record and if I was constantly able to see, are those pills being used? How often are they being used? And that's one of the things that at the time that we were using ECAPs for this study, the family had to bring back the bottle and we would scan it, and that's how we would get the data. They've now advanced it to where they just need to be near their phone and you can get that data. So the ability to continuously monitor how much they're getting, it would be great in clinical practice.
That's brilliant. And also, if you could turn your camera on, I think the audience is requesting some camera time from you so they could actually get to know you a little bit more, even virtually, and hear more about, and obviously we want to hear more about this journey that you've been on around ECAPs and really understanding the medication usage during a study, which obviously for any study involving something that's got a dose, frequency, or timing sensitivity to it is critical, but certainly for a study, there she is. Hello. Good to see you. And, for any study, and love the academic poster behind you. Awesome. And
so I'll brag and she would be embarrassed, but we then started to study people's use in that. And this is my daughter's first scientific poster with her as the first author. And when she moved off to college, I took over her bedroom so she can never come back. And, and that's what's on the wall.
Good for you. That's great. And so given what you've seen now with this new stream of data that you had never seen before in such a critical area, particularly with pediatric patients, but in children, but the idea that you're now seeing some of this new type of data around how pain medications actually being used, is this something that you feel is an ethical bar that researchers are almost being negligent if they're not using this type of adherence platform in their research, or is it a regulatory bar where you feel that folks from the city and other sorts of research agencies should be saying, look, researchers should really be utilizing some sort of medication adherence platform? Or is it a legal issue? Is it really something that from a legal standpoint, we should be protecting patients not only during studies, but after the studies that are relying upon the dose frequency timing? And now let's create a new term, intensity. Pain medications have an intense relationship with patients. And so where the intensity of the medication is now important to be understood, and it should be absolutely a critical mandatory from a regulatory standpoint and a legal standpoint and ethical standpoint to use these technologies in digital health to ensure that our patients are protected not only during studies, but when they're in millions of patients afterwards. Is that what bar do you think we should be setting here for the research community, for the life science community, for the regulatory community in the United States and around the world for these?
So I will tell you really two answers to your question. So first of all, I am continuing to see studies where they are using self-report and recall. And one of the things that in the publication we have out, where the study that we first used this on, when I compared those recalls, if patients reported, let's say the patient was prescribed 20 pills and they reported they used 30, they threw those patients out. And so it always ends up that the patient reports they use less than you could prescribe, because you threw out anybody who you had that evidence that their recall. If the patient was prescribed 20 and they said they used 10, they didn't throw them out. So these studies are continuing to come out, and it's continuing to say that we've overprescribed. And I think it's negligent. It's the cost was not much to add this to our study. And especially now that people are making policy and restricting what we can prescribe. You know, I use that example of your shattered knee. Now, imagine if I gave you 10, how are you going to get back? How are you going to get the next set? Remember, you need to come and see me. I have to see the whites of your eyes to protect my license before I prescribe for you. And just to clarify, because I know a lot of people think, wait a second, you said you're a nurse. Why are you prescribing? In certain states, you can prescribe as an advanced practice nurse, and I am an advanced practice nurse. And so, yeah, I work really hard to be able to treat patients to the full extent of the law. And I'm not going to risk that by over the phone writing you a prescription. And especially, Stan, you're not under 18. You probably know that. And my practice is limited to children. So I'm not going to do that, because that's going to be a red flag and could cost me my livelihood, my ability to treat additional patients. So that's the one point, is I think we need to stop. We need to ask for better evidence before we make the statement that people are overprescribing. The other answer is, if I'm studying the effect of a drug, why would I just do an analysis of intent to treat? Why wouldn't I want the evidence of when are they using it? And let's face it, whenever you are taking a medication more than once a day or twice a day, that third dose becomes this, when do you take it? We know that patients are less adherent when we say take it 3 times a day, because when is your after lunch, Stan, right? Is it after school? If we say take it every 4 hours, you're not going to take a medication exactly every 4 hours. So wouldn't we have a better idea of how that medication works and what's the optimal dosing if we were getting the true evidence of adherence and when patients were taking it? And that's currently missing from our research for both controlled substances and any medications, unless we're using this kind of technology.
This is brilliant. Again, Renee, thank you very much, and a very wonderful, appreciative interview with you today, and continue again with this terrific research. Thank you for joining us today.
Thanks for having me.
Wonderful. Thank you, Dr. Manworren and Stan, for those really useful and informative and honest insights into prescription medication and so forth, especially with our adolescents.